This is MS World, and I'm Dr. Daniel Kantor. When we talk about multiple sclerosis, we also need to talk about other related demyelinating diagnoses. And that's why I'm so happy to be joined here once again by Dr. Brian Weinshenker, who is professor of neurology at Mayo Clinic in Rochester, Minnesota. So, Dr. Weinshenker, we've spoken before several years ago. Just to give us all a refresher, what is neuromyelitis optica, or NMO, and then how have things changed?
Thank you, Daniel. Nice to see you again. NMO is an inflammatory disease of the central nervous system. We say demyelinating, and I think that's true. There is demyelination, but actually the primary target in neuromyelitis optica is the astrocyte, and specifically a protein called aquaporin 4. So in some respects it behaves similarly. It causes optic neuritis and myelitis, which are common symptoms of MS, but it does behave somewhat differently. For example, the myelitis is more severe, is associated with much longer lesions, and we're actually learning that NMO can do much more than cause optic neuritis and myelitis, which is probably going to be the next thing we're going to talk about.
So how do people make the diagnosis when neurologists see a patient and they have optic neuritis, which is a common symptom of multiple sclerosis? How do they know if it's multiple sclerosis or if it's neuromyelitis optica?
And sometimes it's very difficult to tell. So it really does come down to an index of suspicion. There's a lot of things that should raise a suspicion that a patient has NMO. One thing can be certain demographic factors, such as, for example, if the patient is non-Caucasian. But having said that, the majority of our patients are Caucasian. If they have a coexisting autoimmune disease, this is not really very much more common than expected in MS patients, but it is much more common in patients with neuromyelitis optica. If they have a severe attack, if they don't recover, if they have one of these long spinal cord lesions or a long optic nerve lesion on imaging, these would be all things that would lead one to do some additional testing, especially serology for NMO antibody.
How do people treat NMO?
Well, we treat the acute attacks, and that's really quite similar to MS. We use steroids. And in patients who fail, and this comes up more commonly in NMO, we would use plasma exchange. IVIG may be helpful, but there's much less evidence, so I generally recommend plasma exchange if corticosteroids fail. And then the most important thing about treating this condition is giving drugs that reduce the chance of an attack. There are several drugs that are currently available to us, none of them documented to be effective in a randomized clinical trial, but rituximab is widely used, and there's very good evidence that it is effective. Azathioprine and mycophenolate mofetil are another two widely used agents, which are also quite effective. I'd say, strictly speaking, we don't know which is best, although rituximab is very rapidly acting and needs a fairly short period of overlap with corticosteroids that we use for immediate prevention of attacks. We would usually start people on oral corticosteroids for a period of time. With rituximab, we only need about a month of corticosteroids, whereas with azathioprine or mycophenolate, typically 4 to 6 months.
Well, Dr. Weinshenker, thank you so much for shedding some light on this inflammatory diagnosis, and hopefully we've all learned something. Thank you for joining us, and thank you for joining MS World.
Thank you.